we've got all kinds of new therapies out there. So what is the clinical rationale for combining insulin with a GLP-1 receptor antagonist, for example?
I think the complementary mechanisms, I mean, the insulin is obviously mandatory at that stage of the disease, but the GLP-1 adds an extra therapy which is complementary in terms of enhancing insulin secretion. And for some of the GLP-1s, delaying gastric emptying has a marked effect. And postprandial glucose levels can come down pretty dramatically, as well as the preprandials or fasting glucose. So it's a concept of using the 1-2 punch. And generally, we tend to use it more after the oral agents, but that's starting to move up. I think that we're starting to see a greater move after failure of 2 or more oral agents. Starting a GLP-1 insulin combination therapy is certainly either or separately or I believe together is the way to go.
Most of what we said earlier about insulin was around basal insulin, which addresses fasting glucose very well, but does not use the physiological replacement which involves prandial control, insulin secretion during a meal. So you would either have to do that, which is complex, or give something else. And you mentioned GLP-1. So this is a good combination whereby the basal insulin controls the fasting glucose. The prandial instead of prandial insulin, we're using GLP-1 receptor agonists, often 1 injection a day or once a week, that will stimulate insulin secretion at the time of a meal and suppress glucagon at that time, slow gastric emptying, control the weight gain. So lots of reasons for using these two together.
And you know, the studies that have been done are remarkable in that they show that doing twice a day or once weekly GLP-1 on top of basal insulin is as good as, in terms of A1C reduction, 3 times a day prandial insulin with less hypoglycemia and, of course, a favorable weight outcome.
And so it's 3 times a day insulin anyway.
It's a no-brainer.
So we're all in agreement? Well, we can go home now. We'll just start everybody
except that those were separate. Now we are moving towards combining the two in 1 injection, and that's really the key.
And except that GLP-1 receptor agonists are costly. In GLP-1 receptor agonists, they have an issue of GI adverse events. For the most part, they have 25 or 30% nausea, in around 8% of vomiting, that eventually subsides over time. But many people in the real world stop the medication.
Okay, now I heard a little gasp over there.
Yeah, because it's not 20 to 25%. In some cases, it's 9 or 10%.
No.
And yes. And I think that's what the data shows.
Nope.
And I think that, and I think that it's important to point out that up to 25% of people on metformin have side effects and stop taking it. So yes, you have an agent that is highly effective. Yes, there's a percentage of patients, number one, that won't respond, that may have side effects. The medications are highly effective. If you look at persistence, it depends upon what you look at. If you compare to oral meds, yeah, it's not going to be as persistent as you get with oral meds.
But the point I'm trying to say is, for the most part, in the cumulative incidence of nausea is around 25 to 30%. Some people may not have it, but the cumulative incidence is 25 to 35%, and the vomiting is 8 to 10%. In an individual in the real world, they're going to stop this. The other issue that the GLP-1 receptor agonists have been prescribed many times with the expectations of have great weight loss. And when they don't have the weight loss, they tend to stop it. But there's no question, they do work very well. But it has a reality of the GI side effects that has been a problem for many
Julio,
patients.
these side effects are somewhat dose dependent and titration dependent.
Of course.
So we can use lower doses and titrate slowly in order to get there. Now with the pens, it's not always easy, but it's possible.
Well, the only way to titrate slowly is what I conceive the real game changer, because I like to use game changers. I think that the metformin, when it came in 1995, was a game changer. Glargine, when it came in 2000, was a game changer. I think SGLT2s are a game changers. And now putting the two together, the basal insulin with the GLP-1 in the same formulation is a major game changer, because you start very slowly, and as you adjust slowly the basal insulin, you're giving the GLP-1 very slowly also. And then instead of having a cumulative of 25 or 30% of nausea, you have 9%. And that becomes highly effective and very tolerable.
Did I miss something, or did he just agree with you?
You know, I think he would agree with me if he
Well,
if he used the meds the way I use them.
but that's what I was saying earlier, that these drugs are becoming additive in terms of efficacy, and they're limiting the side effect profile. I mean, less weight gain, or in fact weight loss in combination, greater A1C reductions, and the added value of the other benefits that go along with these agents together, I think, make them an ideal combination. And efficacy is, at this stage, when they're used, they're very, you can design them to not only lower, as we said, the preprandial or the fasting, but the postprandial as well,
Now, you were talking about titrating
without having to
up.
give insulin.
You were talking about titrating up, and we've been talking about fixed dose combinations. What's the rationale for the fixed dose combination then?
One injection.
Okay.
You have so you're giving two drugs that
Slow,
are injectable with one
slow
injection.
titration.
And slow titration is another. But really the key for the patient is one injection.
Yeah, let's be careful with the lexicon. Let's be careful with the semantics. You said fixed dose.
Right.
Fixed dose refers to a combination of metformin and a DPP-4 in one pill, or an SGLT2 and metformin in one pill. Here you have a fixed dose. Here with this, the basal insulin and GLP-1, you have a fixed ratio that is titratable.
Okay.
So
That's very
then
good.
you can adjust, because people say, oh, I'm going to give you something fixed dose. No, you need to adjust the thing. No, it's fixed ratio between the ratio of the insulin and the ratio of the GLP-1. And as you adjust both at the same time, and it's titratable.
I get it. That actually does make more physiologic sense, doesn't it?
Yeah.
It's not just, here's your dose, see you next year.
No.
It's the ratio is where we're at. So the FDA's been looking at all of this, right?
I think it's going to be much safer too.
How so?
You know, you can easily. I mean, the algorithms are generally to go up 2 to 4 units depending upon these fixed ratios. But in fact, you can do 1 unit per day. Simple, which we do in the grade. We go 1 unit per day. And it's slow but steady and safe, and I mean, I think it's the way to go, is not to be in a terrible rush. This is more to get it done.
You know, that fast titration is something that I found over time is so much more effective, because, you know, people kind of get excited at the beginning and they're really working hard, and if you take too long to get to goal, there's 2 things that happen. They think, oh, insulin doesn't work because my sugars aren't looking better, or they get tired of titrating and then quit testing and quit titrating. So I like that 1 unit every day. I think it really has improved the
works
patients
extremely
getting
well
to goal.
in grade.
The Canadians actually did this study
Yeah,
and
yeah.
showed that 1 little unit a day, if the blood sugar is above 100, you go there and it's totally non-threatening.
Non-threatening.
Totally non-threatening.